righty, very good. Let's go ahead and call this November, my goodness, meeting of the Medical Services Board to order. Mr. Sykes, would you please help me with roll call?
Certainly, this is Chris Sykes. Laura Carroll.
Present, good morning.
J.K. Costello.
Here.
Morgan Honey. Keep an eye for him. Amanda Jaslinski. We will keep an eye. William Kennard. Barry Martin.
Present.
Kasana Littler. James McLaughlin.
Here.
Christina Mulkey.
Here.
David Pump.
I am present.
Madam President, we do have a quorum.
Wonderful. I will apologize in advance. I am having technical problems out here on the Western Slope, and my computer keeps switching cameras on me. So, whatever you see on the screen, it's still me. All righty, and with that, we are going to start with announcements. The date and location of the next Medical Services Board meeting is scheduled to be held Friday, December 12th, 2025, beginning at 9 a.m. virtually and in person at 303 East 17th Avenue, Suite 1100, Denver, Colorado 80203. If you are listening via audio stream and lose the connection, please click again on the link to rejoin the meeting. Closed captioning is available on your Zoom toolbar, and staff will chat out instructions, and please reach out if you need assistance. Please identify yourself when speaking comments. They are part of the public record. It is the responsibility of the Medical Services Board to adopt the rules that govern the department's programs through consideration of stakeholder input in alignment with the department's mission and in the best interest of Coloradans. There is testimony sign up for the open forum and for each rule. If you need help finding the rule in which you are interested, please ask staff for help. Please keep your testimony related to the rule being discussed. Public comment will be limited to 2 minutes. At the end of 2 minutes, your time will be up and we will move on to the next individual signed up to testify. Thank you. All righty, and with that, team, I will take a motion for an approval of the minutes from last month.
Barry Martin, so moved.
Thank you. May I have a second, please?
Dave Pump, I second.
Thank you, Mr. Pump. All in favor, please say aye.
Aye.
Aye. All opposed? Abstentions? Thank you. Minutes pass. And we are headed into the rules portion. We are getting started straight away with our emergency adoption agenda. And documents 5 and 6 are going to be presented together, as we have started doing on this board when there's an identical rule for both Medicaid and for CHIP. And it looks like we have got Rachel in the house this morning. Good morning, Rachel.
Morning, Madam President and Board. And just to clarify, they are slightly different from each other, but they're very much related. And so we thought it would be most efficient to bring them together this morning.
Thank you for checking me. Go ahead, Rachel.
Thank you. All right. My name is Rachel Larson, and I am a compliance and policy for the excuse me. I need more coffee this morning. I'm a compliance and policy advisor for the department. I'm here to present 2 related rules today, MSB 25-4-28-A, revision to the medical assistance rule concerning coverage for abortion services, and CHP 25-7-1-A, revision to the Children's Health Plan rule concerning coverage of abortion services. I'm joined today by a number of individuals from the department who are experts in this area of policy and who will be available to help answer any questions that you may have. Next slide, please. As an overview, these rule proposals implement Amendment 79 to the Colorado Constitution and Senate Bill or SB 25-183, making abortions a constitutional right. Colorado voters approved Amendment 79 during the 2024 general election. Amendment 79 repealed the state constitutional amendment prohibiting the use of public funds to cover abortions. The amendment also added a state constitutional amendment for the right to an abortion and prohibiting Colorado from denying that right in any way. SB 25-183 changes state law in accordance with Amendment 79. SB 25-183 includes abortion care in family planning related services and requires that abortions be paid with state funds only. SB 25-183 also requires the Medical Services Board to include abortion care in the schedule of healthcare services available to pregnant persons that are enrolled in the Children's Basic Health Plan, Rule 10 CCR 2505-3. These rule proposals today seek to implement these legislative mandates with an effective date of January 1st, 2026 for both rules. Next slide, please. These rule proposals are brought today as emergency rules to comply with Amendment 79 to the Colorado Constitution and SB 25-183, which was signed April 24th, 2025 by Governor Polis with a January 1st, 2026 effective date. The department immediately put teams together to analyze the requirements and to implement next steps for this legislative mandate. After the department gathered information and conducted research, the department held a stakeholder engagement session in September of 2025 to inform members and providers of the legislative changes. Given the condensed timeline required for research, stakeholdering, drafting of rule language, alignment with systems changes, as well as the immediate needs of members in light of changes in federal law and policy about these services and access to these services, the department was unable to utilize a standard rulemaking timeline. Therefore, these proposed revisions are brought today as emergency rules. Next slide, please. There are a few changes to Section 8.770, the Medicaid rule regarding abortion services. You will see some technical changes such as renumbering, changing client to member, and Colorado Medicaid to Health First Colorado. You'll also see in covered services removal of definitions as well as removal of the life endangerment and rape or incest language. Plus, there's more expansive language in alignment with the legislative mandate. There's also some clarification on reimbursement now in the rule. Finally, the rule proposal removes certain documentation that's no longer required. The effective date of these changes is added as January 1st, 2026. Next slide, please. Regarding the CHIP rule or CHP rule related to abortion, Section 2505-3, you'll see similar but slightly different changes. First, there are technical changes such as renumbering. Next, we have the addition of abortion under preventative routine and family planning services. And then finally, there's the removal of the elective termination of pregnancy and life endangerment language. We have also added an effective date of January 1st, 2026. Next slide, please. The department is conducting a stakeholder engagement process regarding the proposed policy changes through a stakeholder meeting for the public, presentations to existing advisory groups, and an ongoing opportunity to submit feedback electronically. Stakeholder questions were responded to live during the meeting and through publishing a question and answer document. Stakeholder questions were technical in nature, and no adjustments to the proposed policy were identified after reviewing the stakeholder feedback. All feedback and department responses are documented in the stakeholder logs for your reference. Board members can access the stakeholder logs and summaries on the member website under the rules. Any additional feedback the department receives will be added to the logs and summaries for the board to review before permanent adoption of these rules. Next slide, please. We thank you so much for your time this morning, and please let us know what questions you have on these two rules.
Thank you, Rachel. Do
Thank
we
you.
have do we have any questions from the board? Hearing none. Mr. Sykes, do we have anyone signed up for public testimony?
This is Chris Sykes. We do. We have Jay Hope with us in the room.
Good morning, Jay.
Good morning.
We have 2 minutes on the clock for you.
Thank you. Thank
You
you.
betcha.
Thank you for the opportunity to speak today. My name is Jay. I'm a registered nurse and I worked in direct patient care for over a decade. Currently, I'm a second-year law student at the University of Colorado Law School. I'm here to express strong support for the proposed rule changes on Document 5, implementing Amendment 79 and Senate Bill 25183, which finally allow Health First Colorado to cover abortion care using state funds. These changes are not only legally required, they are essential to protecting patient privacy, dignity, and access to necessary health care. First, I want to emphasize the importance of ensuring that abortion services are covered regardless of the reason for the abortion. Amendment 79 made clear that abortion is a constitutional right in Colorado, and Senate Bill 25183 created a state-funded program to ensure that all Health First Colorado members can actually access that right. These proposed rules make good on the community by expanding coverage to all members who need abortion care rather than limiting access based on circumstances or imposing harmful barriers. Equally important is the removal of outdated and intrusive documentation requirements that previously forced patients and providers to disclose deeply private information. These requirements, outlined in the existing 8.7440 for D through G sections, compromised patient privacy and created unnecessary administrative burdens for both patients and providers. By removing these disclosure mandates, the department is taking a necessary and overdue step to safeguard patient privacy. Medical decisions about whether and why to seek an abortion are deeply personal. No patient should have to justify their reasons to the state or expose sensitive medical history in order to access a constitutionally protected healthcare service. The new rule appropriately treats abortion care as any other covered family planning service, consistent with an updated statutory framework and constitutional protections. Finally, I want to recognize that ensuring abortion services
Thank you so much, Jay. That's time. Do we have a response from the department?
We really appreciate your feedback. Thank you so much.
Do we have any questions from the board?
I have a question.
Go ahead. I see you, Amanda. Good morning.
Thank you. Good morning. This is Amanda Jashinsky, and I just had a quick question as to whether these rule changes at all impact the Colorado parental notification law for minors seeking an abortion, and how the new law, any new laws might need to address that in order to be consistent with our Constitution.
Rachel?
Let's see, Amy Dixon, would you like to address that?
Yes, hi. Good morning, Madam President and Board. My name is Amy Dixon. I'm the Benefits Division Director at the department. To answer that question, this does not change any other statutory requirement for parental notification. This is only directing the department to cover abortion care using state funds.
Thank you.
Do I have any other questions from the board? Hearing none. Mr. Sykes, do we have anyone else signed up for public testimony today?
This is Chris Sykes. We do not have anybody else signed up for testimony on this rule.
Very good. Then I will accept a motion first on document 5.
I'll make the motion. Can I move for just document 5 first and then?
Yeah.
That's the plan. Yes, thank you for clarifying.
Sure. Madam Chair, this is J.K. Costello. Move the emergency adoption of document 5, MSB 25-04-28-A, revision to the medical assistance rule concerning coverage for abortion services, Section 8.770, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Thank you, Dr. Costello. May I have a second, please?
Madam Chair, this is Susanna Littler. I second.
Thank you, Cassandra. All in favor, please say aye.
Aye.
All opposed?
Oppose.
I'm sorry, I can't see who that is. Would you
This
please
is
announce it for
David.
record?
This
Thank
is
you, David.
Oppose.
Thank you, David. I appreciate you. Any abstentions?
Yes, this is Christina Mulkey, abstain.
Very good. So do we still have a pass on that, Mr. Sykes?
This is Chris Sykes. We do. It passes with 8 yes, 1 nay, and 1 abstention.
Very good. I appreciate you keeping track of the math for me. And with that, we will move on to a motion for document 6, please.
Barry Martin, I can take that one.
Thank you, Dr. Martin.
Move the emergency adoption of document 6, CHP 25-07-01-A, revision to the Children's Health Plan rule concerning coverage of abortion services, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Thank you, Dr. Martin. May I have a second, please?
This is Amanda Jashinsky. I second.
Thank you, Amanda. All in favor, please say aye.
Aye.
All opposed?
This is David. I oppose.
Thank you, Mr. Pomp. Abstentions?
Christina Mulkey, abstain.
Thank you very much for announcing your names. That makes my job so much easier, team. Thank you. Mr. Sykes, does that also give us a pass as it did on the previous one?
This is Chris Sykes. It is. It's the exact same vote.
Very good. Thank you, team, for muddling through that one with me. And on to document 7, which is also part of our emergency adoptions agenda. And today we have Erin Thatcher with us. Good morning, Erin.
Good morning, Madam President and members of the board. Thank you for having me. My name is Erin Thatcher. I am the participant-directed program supervisor overseeing personal care, homemaker, and self-directed benefits within the Office of Community Living. I'm here today to present Emergency Rule 25-10-23-A, which updates the definitions of Direct Care Services Calculator and Protective Oversight under sections 8.7502.K and 8.7538.C.1 of the Home and Community-Based Services, or HCBS, rules. This rule amends 2 HCBS definitions, which clarify how services are authorized. This formalizes a process that already exists, but is not operationally sound. This emergency rule is necessary to clarify authorization standards for personal care, homemaker, and protective oversight, and to promote consistent and fiscally responsible use of Medicaid resources in alignment with the current budget constraints and Governor Polis's Executive Order D-2520. Without this change, the ongoing overauthorizations occurring will jeopardize the sustainability of the state's Medicaid budget and the entire population of members who receive community first choice services who may be at risk of losing benefits. I want to start with a little background to help guide us today. Since the year 2000, HCBS authorizations have relied on a guidance document known as the norms, which outlines the time and scope for personal care and homemaker tasks. That guidance has evolved over the years and is currently in place in the Direct Care Services Calculator, or DCSC, which is a tool that case managers use to determine the right level of services for each member. You may be familiar with previous iterations, such as the task worksheet or care plan calculator, but this document is now called the Direct Care Services Calculator. In preparation for Community First Choice, or CFC, which launched in July of 2025, HCPF worked with the University of Massachusetts and stakeholder groups in 2024 to update the DCSC and task worksheet to include the age-appropriate standards for children, based on Ages and Stages, which is a developmental milestone resource from the Iowa State University Extension. Stakeholder feedback was incorporated in this process, including a request to rename the phrase norms to something more in alignment with person-centered practices. So our current challenge today is that CFC launched in July, and we have seen some additional utilization that we were not anticipating or expecting. And this is a result of the fact that personal care, homemaker, and protective oversight became available to a much larger population, most importantly, children. Prior to CFC, children had very limited access to personal care benefit, and under that benefit, parents could not be paid to provide the service to their children. Now, under CFC, children have broader access to the personal care benefit, and their parent or legally responsible person can be the child's paid caregiver. So in Medicaid, there are some benefits that are available or might be limited because they are an expected expense of childhood or parental responsibility. The most well-known example I can provide to you today is that diapers are not covered for children under the age of 4. This is because it's an expected childhood expense. Once a child passes the age of 4, diapers may be covered if the benefit criteria are met. And this is our opportunity today to better enforce age appropriateness for personal care and homemaker tasks provided to people with disabilities. Our current operational guidance and age appropriateness of tasks developed has not resulted in consistent or age appropriate authorizations, especially for kids. HCPF has been reviewing authorizations following the launch of CFC, and we found some key trends. I want to provide 2 illustrative examples highlighting our systemic issues. These are not criticisms of families or case managers in any way. It's just trying to give you a picture of what's happening out there right now. So our first case is that we had a 5-year-old who attends preschool 4 days a week, was recently approved for 135 hours of services per week, 112 of which were protective oversight. The other hours were a combination of personal care and homemaker services, and this child has no skilled care needs and only a diagnosis of developmental delay in asthma. So they have needs, but this is pretty excessive. The second case we want to highlight today was a 2-year-old who was approved for 24 hours a day of homemaker and personal care services. The majority of time was associated with household chores like dusting, laundry, and meal preparation. So these 2 examples demonstrate that children who are still dependent on their parents and family to manage activities of daily living like bathing, dressing, house care, meal preparation, given our current operational guidance, most of this care would not have been authorized, but it was. So as a result, costs are much well above projections, and without immediate action to maintain our benefits and the long-term sustainability, costs will continue to rise. I want to go into the rule a little bit more specifically for you today. So the first revision is to the direct care services calculator definition. And what that language change does is it formalizes that service authorizations must follow task standards, which were previously called norms. So task standards are the time a task typically takes to complete and the frequency of tasks per week. Age-appropriate task standards are specific to kids due to the different developmental stages of childhood and the amount of parental support expected. So an example for all of us this morning, cleaning the bathroom takes about 10 to 15 minutes per week. An adult with a disability would receive time for a caregiver to help them clean the bathroom. A 4-year-old would not be expected to clean a bathroom on their own, nor would it be expected to bring in an outside person to clean this bathroom. This is a typical parental responsibility. No time would be approved for a 4-year-old, but as a child ages, time may be allocated if they need support beyond what a typical child without disabilities would require. The next part of our revision is the protective oversight definition, and this has been amended to better define inclusions and exclusions for the task. Protective oversight for children must include an intervention substantially greater than what is typical for a child of the same age without disabilities. For example, a 14-year-old with a documented history of elopement and running into traffic after getting off the school bus could receive protective oversight for the walk home. Whereas it would be expected that a parent of a 5-year-old without these same complexities would accompany their child home from the bus stop. There's one other important component to mention. We added language into this amendment to ensure that providers, case management agencies, and the department are not overly restricting a person's movement without a documented rights modification on file. So in a nutshell, what that means is that we're not putting restrictive interventions in place if we don't have the paperwork to support that. These changes overall give case managers and our vendors very clear guardrails. They strengthen oversight and promote equitable, fiscally responsible service delivery. I do want to mention that this change does not impact skilled care, health maintenance activities, or nurse assessor activities. This is separate and independent from Telligent, our nurse assessor program. This is really specific to case management agencies and the tools they use to do their job. I do want to touch on the fiscal impact as well as some stakeholder engagement. Preliminary data shows that this change will save the department about $8.8 million annually by reducing the overauthorization of these services. In the event that a member has been overauthorized for services, the case management agency will be required to revise the prior authorization request, or PAR, and this would take place at the next monitoring contact or annual assessment, whichever comes first. Without intervention, these expenditures will grow exponentially, further stressing Colorado's budget. There are no additional costs to case management agencies or contractors. We're just simply clarifying standards that already exist operationally, and it strengthens our ability to enforce it. Stakeholder feedback, we have had some good engagement, and we thank our partners at Family Voices, Colorado Cross Disability Coalition, Developmental Pathways, and others for their engagement and commitment to our members and their participation in our age-appropriate task work group last year. We did incorporate feedback wherever possible in the rule, and we commit to providing additional training and resources to our case management agencies to ensure that they have the tools necessary to best support our members through this process. In conclusion, this emergency rule is a necessary step to ensure Medicaid funds are used responsibly and services are authorized fairly and consistently. It supports long-term program sustainability while protecting access for members who truly need these benefits. Thank you so much for your time and consideration of this emergency rule this morning. I'm happy to answer any questions you may have.
Thank you, Erin. Mr. Pump, I see your hand. Good morning.
Thank you, Laura. Erin, this is David Pump, and I wanted to really thank you for the tenderness in which you talked about this issue, recognizing there's going to be a change for some people that will be painful to experience. And I'm very much in favor of this. The thing that super concerns me in this is that even as we are being super tender for these family members and being very careful for them, the examples that you provided specifically seem to be more about fraud in a system where the tools are already in place, the expectation is already in place. We're clarifying, and I always love more clarity. That is super kind. We need to do that. But according to our conversation, this is already an operational process. And when you have a 2-year-old getting, I think the example was a 2-year-old, and the family was getting 24 hours of support. And I might be mixing the examples up. I apologize, but the concept is the same. To do things that a 2-year-old wouldn't do. How does that? I'm sure it's be fruitless to talk about how that happens. I mean, it happens. But what is the state's response? What's the department's response when we find that very specific, those specific things are happening already?
Thank you, Mr. Pump, and thank you for the question. And we're right in this right now. I think our challenge is really understanding not only what's happening, but why. And if I can use an example that might be helpful, that's not like age related. Like think about the Autobahn, like the highway in Germany that doesn't have a speed limit. Like anything goes, you can drive on that road as fast as you want and you won't get pulled over. What we're trying to do is we're trying to put some speed limits in place to really ensure that case managers and families and our stakeholder community has specific things to follow. And while we have this guidance that has existed a long time, we also have this influx of new people into CFC, which is really exciting. We have people who've never been able to receive these services before, but without more strict regulations, without the policy, we really can't enforce systemic change. And so I think the two issues are, number one, volume of people coming on to community first choice. And it has been overwhelming for our case management partners who are doing their very best to make sure that services are authorized appropriately. And then secondarily, looking at like what guidance can we put in regulation to ensure that if there's fraud, if there's waste, if there's something that may be abused, that we can take that regulation and enforce it, whether it be contractually or through appeals, something like that. I will just mention that Candace Bailey is here today. Candace, do you have anything else you'd like to add? You don't have to, but up to you.
I'm sorry, before Candace jumps in, I just want to, for the record, state that was Aaron Thatcher from the department speaking. Thank you very much.
Thank you.
Thank you, Madam President. Thank you, Aaron. My name is Candace Bailey, and I'll just add that we appreciate that, Mr. Pump, and where we can identify clear examples of fraud, waste, and abuse, we absolutely take all of the necessary steps. To Aaron's point, these rules are going to actually help us enforce those items. These are new regulations, and it's less of, do we think that there's a lot of fraud? More of, people are new, they don't know, they don't understand, they don't have the clarity that is necessary within our rules, hence the emergency rule today. So hopefully that helps.
Thank you and good morning.
Madam Chair,
Candace.
if I may respond.
Yes, please.
Thank you so very much. Aaron, and this is Dave Pump. Aaron and Candace, I really appreciate this rule. And with all respect, I don't think the Autobahn's a great example in this. I think maybe the 25 is a great example. And regardless of the number of people who just don't know, if somebody from Germany, using that example, is on the 25, they're still going to get busted by the cop, and things are still going to happen. So I don't think ignorance, especially because this is case managers who are making these decisions and pushing that through, I don't think ignorance is a good defense for the spending of those monies. And of course, I'm also coming to you in full disclosure, having to consider the $1.9 billion that Colorado is short, and the 300 some odd million dollars that are being clawed back from HCPF that directly affects the people that are already receiving services and doing it well. So, man, this feels like I'm going to vote yes, let's put this in. But I just really want to support HCPF clawing back dollars in that process.
If I may, Madam President.
Oh, please, Candace. Thank you.
Thank you so much, Mr. Pump. This is Candace Bailey again. And yes, we appreciate that. And where we are able to identify clear examples of fraud, we absolutely pull back that money. So there's a whole separate process for, identifying fraud and how that works as far as pulling back money, and where we have clear examples and cases and evidence and all of the things that does happen. So this is just to prevent it even further going forward. Anything that has happened in the past, those will follow the different change in the appropriate processes that we have in place. Hopefully that helps.
Dave Pump, I support that, and I'm appreciative of you, Candace. Thank you.
Absolutely. Thank you, Mr. Pump.
Do we have any other questions from the board?
Yes, Madam Chair. Bill Kennard.
I can't see who that. Oh, good morning, Dr. Kennard.
I think I just want to ask, first of all, I'm going to vote a strong hell yes on this, but I am going to reframe Mr. Pump's question and ask the second one. I still don't really understand the driver of this, but when I look at currently 44% of all homemaker authorizations for members under age 18 and 58% of protective oversight authorizations exceed age appropriate standards. So what paragraph 2 under regulatory analysis suggests that half of all this money is inappropriate, has been inappropriate up to this time. And I have the same question. What really drives this? I mean, this money, it seems like I really wonder why, boom, this exponential change. And it's not all just people on there. I don't accept that there's just more volume. You didn't say it was volume, you said it was percentages. And so let's just ask the hard questions. Is this vendors who realize this is a source of funding? Is it case management gets paid because I'm just ignorant to these things. Does case management get paid if someone else gets paid? This is the way these things explode is there has to be a driver that I don't understand. So that's number one. And I just want to highlight it's in your document, 44% and 58%. So wow, of guidelines that are already there. So that's kind of on us. And then the second is, how is this redundant in any way? We faced a rule recently where we talked about the sort of 140 hours a week of ability to take people to baseball games and church, and there was a whole system in place that was paying out a lot of money also that seemed like ancillary services like this. So more comment on the drivers. Obviously, this is an attempt to address that. And secondly, a comment on redundancy in the context, as Mr. Pump said, of our budgetary challenges.
Thank you, Dr. Kennard. And this is Erin Thatcher. I'll respond as I can. I might phone a friend too if I miss something, but I think there's a couple of factors at play. So Community First Choice launched July 1st. So the numbers we are seeing are since July 1st. So it's very concerning to us. But essentially with, again, new people accessing services that were previously unavailable, we have a couple of factors that I think play here. Number one, I think case managers and actually I think most people have a really hard time knowing the difference between ages and like what is a typical parental responsibility and what's a developmental milestone for a child. And so the resources we developed were insufficient to really help guide a case manager. And I'll just speak from experience. I've got two kids with special needs with medical complexity. And I don't know what a typical kid can do at the age of 4 or at the age of 10. So I think we've got some insufficient guidance that we've failed to provide case managers. I think the volume of people coming in has been a contributing factor. And also case managers having really clear delineations that like, this is a no, like we can't do this. It's easier for our case management partners to say to a family, this can't be done, and here's why, than to say like, oh, well, we'll try to get it approved and then put it in. And I will just mention that the example you provided, Dr. Kennard, earlier, that's a different service, but essentially we are looking at members may have different service needs. And so some of this might be inappropriately placed. We're not saying they don't have needs, but we need to make sure the needs are in line with their documented assessment and what their needs really are to keep them safe in the community. I think another cost driver is really the fact that, again, kids are new to this. And so again, as a parent myself, we've never had access to homemaker and personal care. And for a lot of families, that could be a game changer. And I think when you're looking at a potential new service and it's available, why not? Why not ask for it? Really, the boundary is it appropriate? And if we need to say no, how do we do that? And how do we best support our case management partners in giving them guidelines to follow, regulations to follow, so that they can best uphold their decision? Candace, anything else you'd like to mention on the cost drivers or other factors at play?
Oh, I think you did a great job, Erin. Thank you so much.
Thank you, ladies. Did that answer your question?
Dr. Kennard here. Yes, thank you.
Great. Amanda, I see your hand.
Hi, yes, thank you. This is Dr. Amanda Jashinsky. I just wanted to add that as a pediatrician, it is what I get handed to me from case managers and groups that figure out these hours, CNA hours for patients, is often kind of a lot of paperwork and complex to go through during a busy clinic and to audit myself. So I think that speaking as a community general pediatrician, I think a lot of primary care docs would say and providers would say, anything that we can get to help us so that we're not signing off on something that's fraud would be appreciated. It's like I said, I mean, I'm signing off on orders for complex kids every day, and it's hard to figure out, you know, the hours, what are they for? Are they allocated correctly? Similar to the questions provided, you know, if I have a 2-year-old with autism, it's probably appropriate for the mom to help them with bathing, regardless of whether or not they have autism, because I help, you know, 2-year-olds need help bathing, and we know that. But again, I would just like to say that from the provider's perspective, we do sign off on these hours, and it does concern me because I have seen more and more cases of things being sent to me for approval that I am not quite sure is appropriate. And it also then is a detriment to the provider-patient relationship when I have to be the one trying to push back and say no, you know, and I don't want them to just go and hop to the next provider who's going to sign off on things without looking at it. I would also say that we've just seen you know, to the question from Dr. Kennard, I don't know whether it's just a general feeling of a lot of patients in the system and whether people need to try to get things done quickly. And that might lead to less of a, or might have led to less of a case by case, more nuanced approach, which is, I think, what the system needs. I just have one question for the panelists this morning, which is that they cite in number 3 that there are no expected costs to the department or other agencies. Is that because you feel like you have the the individuals available to do these audits and review these cases already in place and to do this more thoroughly?
Thank you, Dr. Jaslinski. Is that?
Yes, that's
okay.
Yeah, it's fine.
Well, doing my very best. So in terms of probable costs, yes, we do have staff that is available to do auditing. We have been working on supplemental resources for a while just because they need to exist. So I think at this point, our goal is to get this in place as soon as possible so we can kind of stop the bleeding, so to speak. And then secondarily, thank you so much for sharing your perspective. I do want to clarify that these services do not require a physician's order or like a note or anything from our provider population. That being said, we still recognize that there are other services out there that a person might need, and these might supplement that, but there is an order process requirement here.
This is Dr. Amanda Schulze. Thank you for the
Excuse me 1 second, Amanda. I just wanted to point out that that was once again Erin Thatcher with the department answering that question. Go ahead, Amanda. You're on mute. There you go.
Sorry. Yes, this is Dr. Amanda Schulze. Thank you for that clarification. I think it would be then notable that there are orders that we are signing off on that I have heard many pediatricians express concern over, but that will be a conversation likely for a future meeting.
Madam Chair, this is Cassie Littler. I wonder if I could ask a question.
Please go ahead, Cassie. Good morning.
Good morning. I was wondering what the estimated or expected cost of adding protective oversight and home care for children was initially for the CFC program, and if this is dramatically off of what you expected when all of these children were able to get protective oversight and home care services.
This is Erin Thatcher for response. Thank you, Cassie, for that question. I don't have that data right offhand, but I will say that's a little bit difficult to estimate because protective oversight has not been available. It's not part of pediatric personal care. It's not part of the other services that we're talking about. This new personal care that's available under CFC, protective oversight is part of that, but it wasn't previously available. So we did anticipate some transitions from people who are receiving certified nurse aid or CNA services, and then people who might have been receiving other skilled health services. But as for a specific number, I don't have that for you this morning.
This is Cassie Littler. Thank you for that. I just wondered, this has not been available for children and is really important for especially our children with special and complex needs who previously didn't have the one-to-one services for protective oversight. And so has been a really needed service. And so I just want to be careful to say that this is all just fraud, waste, and abuse when these children really need these services.
This is Erin, if I may respond.
Please.
Thank you. Thank you, Cassie, for your feedback. And yes, we agree that these services are very necessary and needed. So protective oversight is a part of personal care. So it's a task within the personal care benefit. And what we find a lot is that, for example, a child who might need help with bathing, that wouldn't be protective oversight. It would be bathing. And so sometimes it's just teasing out like, what's actually happening? Is something happening with dressing or, I don't know, meal preparation that potentially needs something different? And protective oversight is really like the kind of the last bucket of support that once everything else is determined, we ask that case managers consider like what else might be needed and really what the purpose is. And so in this rule, one of the things that we've clarified is that we need specific interventions outlined so we know what we're paying for and what the member needs, and making sure that the services they receive meet those needs. So it's not just watching and waiting, but it's intervention related. It's really specific to a member's specific supervisory needs, protective oversight needs. Thank you.
This is Cassie Littler. Thank you for your response. I had a second question, if I may, Madam Chair.
Please do.
Again, this is Cassie Littler. I just wondered about the opposite of what we were talking about when patients get more than they maybe should, is patients who have difficulty advocating for themselves in these situations with healthcare or health management agencies and maybe get less than what they should. And so I wondered if there was a way to, is there a process to contest the number of hours of services in that sense?
This is Erin Thatcher to respond. Thank you, Cassie, for that question. So we definitely have options for folks. I think first and foremost, it's dialogue with the case management agency. So when services are authorized, and we're talking about services, not only community first choice, personal care, homemaker, but also potentially waiver services, which we aren't there. That's outside of the scope of what we're doing today, but case management agencies are well prepared to discuss with families what's available. And then in addition, on the side of self-direction, we have some additional support through what's called information and assistance. So that's kind of specialized case management support to help a member who's self-directing. So either through in-home support services or consumer-directed attendance support services, which both have personal care and homemaker in those benefits. But I would say we can definitely work on developing some resources and really to help people figure out if there's a situation where they don't feel like they have what they need, what do? They definitely have the right to appeal a decision. They can always request something. And if the case management agency is not able to approve it, they would give the member the ability to appeal that decision. But we can definitely work on some additional resources for folks and case managers for like, what do you do if you need more support? Thank you.
This is Cassie Littler. Thanks for that response. I'm a pediatrician in a complex care clinic, and I take care of patients every day who need these services. And I do see both sides, right? Patients who get more services than what I think maybe they need, and patients who have the opposite, who maybe have parents who have cognitive delays themselves and have difficulty, telling the case management agencies what they do and what they need. So thank you for your response.
I appreciate you, Cassie. It's always nice to have information from people who are actually out there doing the work. Thank you so much. Do I have any other questions from the board?
Barry Martin, I have a question.
Go ahead, Dr. Martin. Good morning.
Good morning. I probably should know this, and I tried to research it and figure it out on my own, but the Community First Choice program, was that, I was trying to figure out the difference between that and the waiver programs. And I was wondering, was this program started just to try to get these personal care services, or if you could just explain how community first choice differs from the waivers and why we have it in addition to the waivers.
Thank you, Dr. Martin. This is Erin Thatcher for a response. So Community First Choice is under a different federal authority than our home and community-based services waivers. And several years ago, the General Assembly approved our oh my gosh, I can't even remember the name of the bill at this point in time, but they approved us moving forward with Community First Choice. There is an enhanced match for this service package, and Community First Choice lives within the state plan, which means that someone doesn't need to actually be on a typical HCBS waiver to access the services. So it makes it a little bit easier for people on traditional state plan Medicaid, as long as they meet the targeting criteria to access personal care, homemaker, health maintenance activities, and a couple of other services. And my team said Senate Bill 23-289. Thank you, guys.
Thank you.
Do we have any other questions from the board?
Chairperson Carroll, this is J.K. Costello.
Good morning, JK, go ahead.
Ms. Thatcher, Ms. Bailey, I just want to recognize, I thought this was a sterling exemplary presentation, both oral and narrative, and I feel very, very informed about this. So thank you.
Thank you, Dr. Costello. Do we have any other questions or comments from the board? Hearing none. Mr. Sykes, do we have anyone signed up for public testimony on document 7 this morning?
This is Chris Sykes, pardon me. We have Megan Bowser signed up to provide testimony.
Good morning, Megan. We've got 2 minutes on the clock.
Thank you, Madam Chair. My name is Megan Bowser. I'm the Executive Director at Family Voices Colorado and also a mom of multiple kids with disabilities who access home and community-based services and soon Community First Choice as well. I just wanted to take a minute to comment on this proposed rule. And first and foremost, thank Healthcare Policy and Financing for engaging us and allowing us to participate in this rule revision process and development. I agree that more clarity is needed to promote consistency amongst the utilization, particularly of protective oversight, as we have seen some getting authorized with very, very few hours who have extremely high needs, and then others similar to the examples that Erin shared with you that seem very clearly over authorization. Some of this process highlights many of the concerns that we have with the load on the case management agencies and the case managers themselves. And I wanted to provide a little clarity on what we see there as well. As you guys know, with that massive number of rules that have come to you in this past year, there have been a lot of changes that have happened in the Medicaid program, particularly in the disability program space. And that has put a tremendous strain on the case managers, where we've seen a lot of turnover, a lot of inexperienced case managers who are really struggling to keep up with the many changes and the many expectations that are placed on them. So I think much of this over authorization is not due to malice, but is due to a lack of experience, training, and confusion amidst a very trying and very tumultuous sort of time and year and the expectations on them. My one concern that is left within this rule is having rules that point to outside documents always leaves me a little bit concerned, because there many changes can be made in the future without needing to go through the formal rule and regulations process. So pointing to an outside document where there are no limits and nothing in rule that outlines what those age appropriate norms are leaves me with a little bit of concern, especially with something like age appropriate norms that should not change frequently.
Thank you, Megan. I appreciate you as always. Do I have a response from the department?
Thank you. This is Erin Thatcher. Thank you, Megan, and your team at Family Voices for your collaboration and your insight and your input. We appreciate you.
Thank you, Erin. Do we have any questions from the board?
Madam Chair, this is Dave Pump.
Go ahead, Mr. Pump.
I really wanted to second that conversation or that point of view around the amount of rules and our case management system that has so much turnover and is so difficult to manage on the program delivery side. No matter how people are intelligent and want to do the best thing, that is a real weakness in how we deliver that care, just because it's so difficult. That's all.
I always appreciate your insight, Mr. Pump. Thank you. All righty. Do we have anyone else signed up for public testimony on rule number 7, Mr. Sykes?
This is Chris Sykes. We do. We have Bryce Rafferty signed up.
Good morning, Mr. Rafferty. We've got 2 minutes on the clock for you.
Morning, can you hear me?
I hear you.
Oh, good morning, Madam Chair and members of the board. My name is Bryce Rafferty. I'm here on behalf of CCDC. I want to focus briefly on what this means in real life for affected children and families. First, on the emergency designation, Colorado law reserves the emergency rulemaking for situations where immediate action is imperatively necessary. The pressures driving this rule, budget constraints, projected appeals, longstanding concerns in LTSS, they're not new or sudden. They're the predictable result of policy changes, including how CFC was implemented. Treating those ongoing pressures as an emergency risk turning emergency rulemaking into a routine shortcut, weakening both APA protections and constraining this board's oversight. Second, on member impact and due process. The department's own analysis, as you heard, anticipates about $8.8 million in savings. Yet the rule doesn't clearly spell out how families will be notified and educated or how case-specific needs will be weighed against these new standards. Without those protections, every reduction carries a risk of harm. Third, on the tools application of the standards, this rule effectively binds the Direct Care Services Calculator, adult and child task standards into regulation, but the criteria themselves remain largely invisible to members and their families. They operate alongside the nurse assessor acuity tool standards, which don't uniformly track criteria, have never gone through full APA rulemaking, and have already changed significantly without member notice just a few months after program launch. There's nothing preventing similar changes to these standards. When the true decision-making framework lives with black box tools and standards subject to internal changes absent APA rulemaking and stakeholder engagement, families cannot prepare for assessments, advocate for their needs, or meaningfully challenge those outcomes. My requests are straightforward. Commit to formal APA rulemaking that brings the task standards and their methodology into public discussion. Provide a defined transition period, and critically address the Direct Care Services Calculator and related acuity tools together in a coherent rule package instead of in fragmented emergency rules. Thank you so much for your time and consideration.
Thank you, Bryce. I appreciate you. Do we have a response from the department?
Hi, Madam President. This is Candace Bailey, and I'm going to go ahead and respond. And thank you so much for that, Bryce. I appreciate it. I will note that the department does have a responsibility when we have identified a pretty extreme trend in the moment of a financial and fiscal crisis within the state of Colorado to actually bring forward some solutions around emergency rule. We also did do some stakeholder engagement, and we've worked significantly with a lot of stakeholder partners on all of the age-appropriate guidelines, including CCDC as our partnership. We received direct feedback from CCDC, of which we incorporated into this rule as late as, I think, Monday or Tuesday, actually. So I just want to note that there has been quite a bit of stakeholder engagement, but it is also our responsibility to bring forward emergency rule when we have such an identified clear trend that we need to address so that we can better support all of the case managers, all of the families with the clarity that is needed going forward. So thank you for your time.
Thank you, Candace. Appreciate it. Do we have any questions from the board? Hearing none. Thank you very much, Mr. Rafferty. Do we have anyone else signed up for public testimony this morning, Mr. Sykes?
This is Chris Sykes. We do not have anybody else signed up for testimony on this rule.
Very good. Then I will accept a motion on document 7.
Mr. Barry Martin, I can take it.
Thank you, Dr. Martin. Appreciate you.
Move the emergency adoption of document 7, MSB 25-10-23-A, revisions to the Direct Care Services Calculator and protective oversight definitions, sections 8.7502.k and 8.7538.c.1, incorporating incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Thank you, Dr. Martin. May I have a second, please?
This is James McLaughlin. I'll second.
Thank you, James. Good morning. All in favor, please say aye.
Aye.
Aye. All opposed? Abstentions? Very good. Document 7 passes and we are in recess for 5 minutes.
What rule is
Welcome back, everybody. All righty, is everybody back in the room?
The Buffalo Bills.
Madam Chair.
Community,
This is David online. I'm back.
thank you, sir. Are we all ready?
Momentarily, Madam President. People in the room, we are ready to begin. If we could return to our regularly scheduled seating, it would be wonderful. Thank you.
Thank you, team. All righty, we are still emergency ruling this morning, and we are on to document 8 with our friend David Smith. Good morning, David.
Good morning, Madam President and members of the board. My name is David Smith. I've been at the department now for 16 years, where I've worked on various recovery programs that are actually mandated under federal law. Also with me today, I have Prismar Perez, and Prismar is with the Fraud, Waste, and Abuse Division, and I brought Prismar here because if you have specific questions about the RAC program, Prismar is my go-to person. I will say, after the last rule, I'm feeling a little self-conscious about talking about recovery efforts as well as fraud, waste, and abuse. So hopefully you'll indulge me and take it easy on me. So I'm here to present document 8, numbered MSB 25-10-23-B. The rule change is titled RAC Program Technical Changes. This rule amends portions of section 8.076. This is the portion of our rules that address program integrity. The Recovery Audit Contractor Program, or as we refer to it as RAC, is performed by a contractor, and that contractor's duty is to identify underpayments as well as overpayments to providers and to subsequently recoup those overpayments. Accordingly, the RAC program impacts any provider that provides goods and services to the Medicaid program. The rule before you is an emergency rule, which means that the immediate adoption of the rule is imperatively necessary to comply with state or federal law or federal regulation, and compliance with the standard rulemaking process would be contrary to the public interest. Immediate adoption of these changes to the existing rule is necessary to comply with Colorado Senate Bill 314. This is an act that went into effect on August 6th of this year. Compliance with the non-emergency rulemaking requirements would be contrary to the public interest by delaying the implementation of RAC audits, which promote fiscal integrity for the Medicaid program. Moreover, a delay of these provisions would delay changes that actually benefit providers undergoing RAC audits. These emergency rule changes also will decrease the abrasion between the department and providers undergoing these audits by clarifying an existing rule. A note about Senate Bill 314, this was a statute that substantially rewrote how RAC audits are performed. The bill was the result of intensive negotiations between the Hospital Association and the department, as well as with other providers who were genuinely concerned about how the RAC audit program functioned. A note about the 3 specific changes to the rule that are before you today. Senate Bill 314, which governs the RAC audit process, contains very specific requirements, due process provisions, and those provisions conflict with the existing program integrity rule. The specific provisions that we're seeking to accept from operation of the BRAC program deal with providing documents in the course of an audit, informal interviews between the department and the provider, as well as notice requirements. Senate Bill 314 contains specific provisions regarding providing documents, regarding providing notice, as well as the levels of reviews, which providers are able to discuss and seek reviews of audit findings with the department, as well as the contractor who performs this work on behalf of the department. I urge the board to adopt these changes on an emergency basis in order to comply with Senate Bill 314, as well as federal law. Federal law actually imposes the requirement that the department engage a RAC contractor to perform these audits. But I also really would like to highlight that this is an important fiscal integrity tool, and that these changes will aid our implementation of the bill in order to resume these audits. Failure to adopt these modifications to the rule would set up conflicting requirements between Senate Bill 314 and the rule, and would also place the department out of compliance with the new legislative requirements. With that, I'm happy to answer any and all questions.
Thank you, David. We appreciate you. Do I have any questions from the board?
Madam Chair, Dr. Kennard here.
Good morning, Dr. Kennard.
Forgive me again. I've been on the board a little more than 4 years, and RAC is new to that is a new entity to me. Would you indulge us, David, with a really quick 20,000-foot overview? What's the pie chart of what RAC actually accomplishes? Like when you have successful audits that either stop money going out or recover money, is this something, well, in 2024 we got X million dollars back from hospitals, we got X million dollars back from home care agency. I'm trying to get a sense of, again, what does that pie chart look like of what does RAC accomplish? And in what way might this rule change impact that? Is that a fair question?
Most definitely.
Okay. Wasn't too bad, was it?
No.
Oh, okay.
So these RAC audits are.
You should state your name.
Oh, yeah.
David Smith.
Yeah.
These RAC audits are a post-payment mechanism. So the service or supply has already been provided to the member. So the contractor will audit claims to look at whether or not the claims were properly submitted, and follow department guidelines, and seek to identify any overpayments that might have occurred as a result of the billing process. There are currently operationalized 2 categories of audits. You know, we look through the claims data and do what we call automated audits, and those look at really technical claim submission requirements. But then there's also a more detailed audit called the complex audits, and those are actual clinical audits where we're looking at clinical judgment and whatnot. An audit program, it really covers the span of all providers. Currently, given that the General Assembly has directed us to completely overhaul and retool the program, there's also another provider advisory board that is helping the department define these specific audit scenarios, and all of that is in process at the current time. Going back into my memory, I think the level of recoveries were, somewhere in the neighborhood of $20 million per year of overpayments that the contractor identified. Since a significant portion of the Medicaid spend is to hospitals, a lot of audits focused on the hospital category of provider. But as background, vis-a-vis Senate Bill 314, there was a lot of abrasion between the contractor and the provider community. The bill actually sets up greater due process for providers, a lot more input for providers into how these audits get conducted. Actually the bill is a good step forward for both the department and the provider community.
Thank you, Dr. Tom.
James McLaughlin here, Madam Chair.
Go ahead, James.
Yeah, I having reached out and worked with these folks before, one of the things that I'd like to say is that not only do they do enforcement, but they're also there to answer questions and to help people better understand policy as well. And it's, encouraging compliance is always so much better than enforcing regulation. And what I would love to do is I'd like to propose that maybe we invite them back to do a presentation in the future on the RAC, so we can better understand, because I do think the work they do is fascinating. Obviously, by all means, please ask the questions that you need to ask to make sure that the rule today is appropriate. But in the interest of respecting everyone's time, Madam Chair, which I know is super important to you, I was wondering if maybe we could invite them back to do a full presentation for us at some point in the future.
I love that idea, Mr. Sykes. Is that something you can make so?
This is Chris Sykes. Yes, I am.
Appreciate you, and thank you for the feedback, Mr. McLaughlin. Do we have any other questions from the board?
Madam Chair, this is Cassie Littler. I do have a question.
Go ahead.
I wondered about what types of claims, like for instance, in alternative payment models, are you auditing those claims? Or is it just the fee-for-service claims? Because there is the APM2 model where, you get a per member per month and then it's trued up, right, at the end of a certain time period. And so in the APM2 model, providers who got overpayment in the second year and in subsequent years could keep that overpayment. And so I wondered if this was subject to the RAC audit.
My name is Prismar Perez. I'm the supervisor for the RAC team, and we only audit fee-for-service claims.
Great, thank you for that.
Thank you. Do we have any other questions from the board? Hearing none. Mr. Sykes, do we have anyone signed up for public testimony on rule number 8?
This is Chris Sykes. We have Bryce Rafferty signed up.
Heidi ho, Bryce.
Hello again. Can you hear me?
Hi.
Good morning, Madam Chair and members of the board. My name is still Bryce Rafferty from CCDC. I want to start by recognizing the work that went into this bill. This bill was a hard-fought compromise to make RAC audits fairer and more transparent while protecting the Medicaid budget. My concern is that this rule, as drafted, risks undercutting these goals in ways that will land hardest on people with disabilities who depend on higher cost long-term care benefits. The rule is very specific. It carves out RAC audits out of 3 existing protections the provider interview provision, the standard overpayment notice language, and the automatic overpayment finding when documentation is late. I understand the intent. RAC now has its own framework and statute, but the rule mostly says this doesn't apply to RAC without clearly spelling out what does apply in one place. That omission matters. Providers need to know in plain terms, what does a RAC notice look like? What are the timeframes for preliminary findings, exit conferences, dispute processes, and appeals? What happens if documentation is late but not intentional? When those answers aren't clear, providers facing RAC audits are more likely to freeze services, pull back from Medicaid, or maybe exit altogether. And continuity of care for members becomes collateral damage here. I'm also concerned about the emergency posture again. The bill has been on the books for months. There was time to engage LTSS providers and disability advocates and bring you a full rule package that both resolves conflicts and clearly maps RAC procedures. Using emergency rulemaking now fits a broader pattern where emergency rules are becoming the norm rather than the exception, and that erodes trust. My requests are modest. Put RAC procedures in rule in one coherent subsection. Build in explicit continuity of care protections when RAC findings involve LTSS providers. Pair these changes with robust, accessible provider education on how RAC is different from other audits. And if those pieces aren't ready, move this into full rulemaking instead of emergency adoption. I want to emphasize I support rooting out improper payments, but
Thank you, Bryce. We appreciate you. Do I have a response from the department?
Madam President, this is David Smith. Thank you, Mr. Rafferty, for your comments. Rulemaking is a quasi-legislative process. It operates as a delegation from the General Assembly. In the case at hand regarding RAC audits, the General Assembly has given the department very prescriptive guidance as to how RAC audits should and will be conducted. And in fact, they provide greater fairness and greater due process to the provider community. This is evidenced by the fact that, as Mr. Rafferty noted, Senate Bill 314 was a very hard-fought bill. It was the result of extensive back and forth with the provider community who were aggrieved regarding how RAC audits were being conducted. And the bill reflects a compromise and a much fairer process so that parties can undergo RAC audits and the department can comply with federal law, and the providers have recourse as well as an additional appeal mechanism as well as additional notice requirements that are not presently contained in rule. So going back to my earlier comment, rulemaking is really intended to fill in gaps where the legislative language doesn't provide clear guidance. That's not the case here. The case here is that Senate Bill 314 contains very prescriptive guidance regarding how RAC audits are conducted.
if I could just quickly respond, Madam Chair.
Please, Bryce, go ahead.
I appreciate that response. This is Bryce Rafferty with CCDC. The issue with statutory versus regulatory provisions is that the regulatory provisions are the ones that are most visible, particularly by the providers, by people on the ground. Statutes are much more inaccessible, and while the statute may cover these details, it really matters to put those details into rules so that we have a comprehensive regulatory scheme. It wouldn't conflict with the statute, and so therefore I think it should be included in rule just to make it more transparent and visible for all parties affected. Thank you.
Thank you, Bryce. Do we have a response to that?
Yes, this is David Smith. Mr. Rafferty states an opinion that rules are more transparent. Both rules and statutes have the full force and effect of law. I personally, if I Google the statute comes up much more quickly than Googling the rule. So, in my opinion, the statute is readily accessible. But more importantly, to address Mr. Rafferty's concerns, the department looks forward to bringing rulemaking with the full, notice and comment provisions that standard rulemaking affords the parties. As we get further into implementing these new provisions, and moreover, the department looks forward to presenting greater information as we implement the new terms of the program to the board. Thank you.
Madam Chair, I have a question. This is Cassie.
I'm sorry, I can't see who's speaking to me. I'm sorry.
This is Cassie Littler.
Hi, Cassie, go ahead.
I just had a question about section 8.076.2.h, where a provider who has a review or an audit can request an interview in person or by telephone, and that the request for an interview described in this subsection does not apply to audits conducted by the RAC. So if a provider wants to talk about it, who are they going to talk to about it?
This is David Smith. Excellent question. I appreciate the question. The reason why I accepted the RAC program from this particular provision is that the timeline follows a much different process in the rule. I'm sorry, in the statute. So if a provider wants to talk to the RAC contractor, there is hard-coded into the statutory language a 2 business day time frame with which the contractor has to get back to the provider. But also the timeline follows a different process. So the audit's performed, there are preliminary findings, there is an opportunity for the provider to engage with the contractor on those preliminary findings in the course of 2 levels of review. For complex audits, there's a new mechanism called an exit conference. There's a subsequent level of review called the informal reconsideration. And all of those provisions give the provider an opportunity to engage with the RAC contractor and the department regarding any comments, concerns, questions that they have regarding those audit findings. This provision didn't make a lot of sense because it imposes a conversation before the actual preliminary findings are created. So it just from a pragmatic operational standpoint, it doesn't make a lot of sense. It doesn't really fit in. But bottom line is that there are very prescriptive provisions in the statute requiring the department and the contractor to meaningfully engage with providers.
And if I may speak as well, this is Prismar Perez speaking. I do want to mention that provision is more talking about, like, from the bill, there is specific timelines that the provider may speak or may schedule the exit conference or an IR meeting. So that's what that provision is speaking to. And as well as we are going to implement additional rulemaking into the statute to be more specific about the changes that happened to the bill to implement that into statute and rule.
Thank you, Prismar.
Do I have any other questions from the board? Hearing none. Thank you, Mr. Rafferty. You always give us things to talk and think about. I appreciate you. Do we have any other public testimony, Mr. Sykes?
This is Chris Sykes. We do not have anybody signed up for public testimony on this rule.
Very good. Then I would accept a motion on document 8.
This is James McLaughlin. I can take that one.
Thank you, Mr. McLaughlin.
I move the emergency adoption of document 08 MSB 25-10-23-B revision to the Medical Assistance Act rule concerning RAC, or RAC program technical changes, section 8.076.2.G and 8.076.2.H and 8.076.2. I believe that's I, incorporating the statement of bases and purposes and specific statutory authority contained in the records.
Thank you, Mr. McLaughlin. May I get a second, please?
Dr. Kennard, I'll second.
Thank you, Dr. Kennard. All in favor, please say aye.
Aye.
All opposed? Abstentions? Very good. Document 8 passes. On to document 9. I just want to give some foreshadowing that document 9 and document 1 that is going to be up for final adoption are going to look very familiar, teams. So let's be prepared for that. For right now, let's do document 9 with our friend Scott Lindblom. Good morning.
Morning. Thank you. Can you hear me?
I can indeed, sir.
Very good. Well, good morning, Madam President, members of the board. My name is Scott Lindblom, Director of the Provider Relations and Fiscal Agent Operations Division here at the Department of Healthcare Policy and Financing. Today, I'm presenting document 9, MSB 25-11-6-A, an emergency rule adoption for a minor update to the timely filing rule 8.043. As a reminder, timely filing refers to the period providers have to submit claims after the date of service. And as you just mentioned, you may recall that you approved the same emergency rule back in August. However, due to administrative error with the filing the notice of rulemaking for final adoption, we need to bring it back before you today. This update simply aligns rule language, what we already do in practice. Providers have 365 days to submit claims rather than the 120 days currently stated in the rule. The 365-day time frame is the maximum allowed under federal regulations. It reduces administrative burden, supports provider participation, and gives providers flexibility they need to submit complete and accurate claims. And importantly, this change requires no additional funding, and it has no negative impact on providers because the 365-day period is already in place operationally. So I'll pause there for any questions.
Thank you, Scott. Do I have any questions from the board? Hearing none. Do we have anyone signed up for public testimony today, Mr. Sykes?
This is Chris Sykes. We do not have anybody signed up for public testimony on this rule.
Very good. Then I will accept a motion on document 9.
Madam Chair, this is Cassie Littler. I move the emergency adoption of document 9, MSB 25-11-06-A, revision to the Medical Assistance Act rule concerning timely filing, section 8.043, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Thank you, ma'am. May I have a second?
I'll second. Jason Costello.
Thank you, Dr. Costello. All in favor, please say aye.
Aye.
Aye. All opposed? Abstentions? Very good. Document 9 passes. We are on to the final adoption portion of the program. And well, gosh and golly, we've got Scott Lindblom to discuss document 1 with us.
Thank you, and good morning again, Madam President, members of the board. For the record, my name is Scott Lindblom, Director of Provider Relations and Fiscal Agent Operations Division, and I'm now presenting document 1, MSB 25-09-25-A for final rule adoption. This is the same timely filing rule update to 8.043 you just heard under the emergency rule adoption in document 9. There have been no changes to the content since your emergency approval just moments ago. But to restate briefly for the record, this update aligns the rule text with our current practice of allowing 365 days to submit claims. This replaces the outdated language still referencing 120 days. And again, this time frame is the maximum allowable under federal regulations. It reduces administrative burden, supports provider participation, and provides the necessary flexibility for accurate claim submission. There is no fiscal impact and no negative impact to providers, as the 365-day period is already being used today. So I will pause there for questions.
Thank you, Scott. Do we have any questions from the board? Anyone signed up for public testimony, Mr. Sykes?
This is Chris Sykes. We do not have anybody signed up for public testimony on this rule.
I will accept a motion for document 1.
This is James. I can take that.
Thank you, sir.
I move the final adoption of document 01 MSB 25-09-25-A, revision to the Medical Assistance Act rule concerning timely filing, section 8.043, incorporating the statement and basis and purposes and specific statutory authority contained in the records.
Thank you, James. May I have a second, please?
Barry Martin, I'll second.
Thank you, Dr. Martin. All in favor, please say aye.
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 All opposed? Abstaining? Very good. Document 1 passes. We are on to document 2 with Jeff Whitreich. Did I say that? Whitreich? Did I say that right? I'm so sorry.
Apologies, you're very close. It's Whitreich.
Thank you, Whitreich.
You're not the first nor the last, but you were close enough, so thank you.
I appreciate it. Thanks.
Good afternoon, good morning, everybody. My name is Jeff Whitreich. I am the Provider Fee Unit Manager at Healthcare Policy and Financing. I'm here to submit for final adoption Medical Services Board 250925B, revisions to the Medical Service Act concerning healthcare affordability and sustainability provider fees and supplemental payments. Kind of similar to before, none of the language here is being changed. Kind of what this language is meant to do is kind of establish the per diem fees that we need to collect for federal fiscal year 24-25. Kind of how Chase works is we as a state assess a fee on provider communities, either hospitals, nursing homes, use those fees to draw down federal matching funds to then pay those back to hospitals or nursing homes through a monthly supplemental payment. Every year, we as a department revise what those fees amount to be based on the changes in the funding obligation for that year. What these rules do is simply revise the per diem fees that we need to collect so that the amount of fees we could collect match the funding obligation for federal fiscal year 24-25. In addition, there are a few minor changes to supplemental payments based on changes we need to make for dish payments or things like that. But really the intent and purpose of this is to make sure we collect enough fees that are necessary to cover our funding obligations. That was a very quick overview. I'm here to answer any questions anybody has.
Thank you. Yeah, go ahead, James.
Thank you very much, Madam Chair. Quick question, two-part question. First of all, how does this play in, or does it play in at all to the emergency meeting that we had back in July, on July 3rd? And then did this rule go through the Chase Board for review first? And did they have any input or say in it?
Two good questions. So for the first one is, yes, we had an emergency rule in July to revise kind of the ceiling of fees that we can collect through Chase. If you look at page 2 of 6, that language is there. We did make minor tweaks to the language to make sure we understand that is kind of a ceiling of amount we can collect to hopefully align with what is required with HR 1. So these rules have those changes, and they are here. You can see that in 8.3B, 3A, and 3B. In addition to your point about the Chase Board, so yes, these rules have been presented to the Chase Board. They approved this model in, I think it was September of 2025, and they are yes, they are comfortable and they are good with the kind of proposed regulations and recommend the Medical Services Board approve the language in front of you today.
Awesome. Thank you very much.
Thank you.
Is Laura still with us? This is Chris Sykes.
Madam Chair, that's all I had.
You can look on.
Actually,
She's
might have lost
frozen. Oh, I believe Laura is frozen. So if you can hear us, Laura, that line of, that question is completed. And yes, we just lost our vice president on a, oh, Barry, I think you're gonna have to step in real quick.
Nope, I'm back. I don't know what happened. Here I am. I was just texting you. Was that me or was it you guys?
We are uncertain, but we're happy to have you back.
Great. I'm just trying to figure out if I need to go, have Jed shake the router or something. So if you guys figure out that was on my end, will you please message me accordingly? Excellent. Okay, so I cut out mid-answer, I believe. So did everybody's questions get answered in my absence?
Madam Chair,
Wonderful. Do I have any other questions from the board? Hearing none. Mr. Sykes, do we have anyone signed up for public testimony?
This is Chris Sykes. We do not have anybody signed up for public testimony on this rule.
Wonderful. With that, I will take a motion on document 2.
this is James McLaughlin. I can take that one, Madam Chair.
Thank you, sir.
So I move the final adoption of document 2 MSB 25-09-25-B, revision to the Medical Assistance Act rule concerning healthcare affordability and sustainability provider fees and supplemental payments, section 8.3000, incorporating the statement of bases and purposes and specific statutory authority contained in the records.
Thank you, Mr. McLaughlin. May I have a second, please?
Madam Chair, this is Cassie Littler. I second.
Thank you, Cassie. All in favor, please say aye.
This is
Aye. Did I hear somebody interjecting?
That's David, and it was my mistake. I'm just saying aye.
Wonderful. All opposed? Abstentions? Wonderful. Document 2 passes. On to document 3 with our friend Andrew Abalos. Good morning, Andrew.
Good morning. Can you hear me?
I can indeed, sir.
Great, thank you. So good morning once again, Madam President and members of the board. My name is Andrew Abalos. I'm the Facility Rates Section Manager of the Fee-for-Service Rates Division here at the Colorado Department of Healthcare Policy and Financing. And I'm here to present Document 3, MSB 25-09-25-C, revision to the Medical Assistance Act rule concerning hospital rate setting authority for final adoption. This was originally presented by Kevin Martin of the Fee-for-Service Rates Division as an emergency rule during the September 12, 2025 meeting when it was adopted by the Medical Services Board. On July 4th, President of the United States, Donald Trump, signed H.R. 1 into law through the reconciliation process. H.R. 1 increases the federal budget deficit and is causing an immediate and significant negative impact to state revenue, reducing total state revenue by over $1.2 billion in the current fiscal year, eliminating the state surplus and putting Colorado's budget roughly $800 million out of balance in the current fiscal year 25-26, and reducing revenue to the state by approximately $700 million in fiscal year 26-27 and fiscal year 27-28. On August 28, 2025, Governor Polis signed Executive Order D-2514, and on October 31st, 2025, Executive Order 2520, both of which reduce general fund expenditures to bring Colorado's budget into balance for the current fiscal year, state fiscal year 25-26. Some of the reductions will impact programs administered by the Department of Healthcare Policy and Financing. So this rule is to allow the department to implement some of these rate reductions that are needed in response to these executive orders and potential future executive orders impacting these rates and to comply with state law. Thank you for your time and consideration, and I'm happy to answer any questions.
Thank you, Andrew. Do we have any questions from the board?
Madam Chair, this is Cassie Littler. I do have a question.
Go ahead, Cassie.
The language says that the Medicaid inpatient base rates may be reduced during the state fiscal year in response to an executive order. I realize that this is not useful this year, but in future years, would it be possible to say that rates could be increased with executive order?
Yeah, it's certainly this could be. This is Andrew. That's certainly something that could be useful, and we can assess that just to allow sort of the multi directions that they could be. The rates can change.
Great question, Cassie. Do we have any other questions from the board? Hearing none. Mr. Sykes, do we have anyone signed up for public testimony today?
This is Chris Sykes. We do not have anybody signed up for public testimony on this rule.
Very good. Then I will accept a motion for document 3.
I'll move, Madam Chair. This is JK.
Thank you. I can't. Oh, thank you, JK.
Move the final adoption of document 3 MSB 25-09-25-C, revision to the Medical Assistance Act rule concerning hospital rate setting authority, sections 8.300, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Thank you. May I have a second?
Barry Martin, I'll second.
Thank you, Dr. Martin. All in favor, please say aye.
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 All opposed? Abstentions? Very good. Document 3 passes. And we are on to the initial approval portion of the program. We've just got one on initial approval today. And with us from the department is Corinna Barak. Good morning.
Good morning, Madam President. Thank you. Hello to members of the board. My name is Corinna Barak, and I'm in the Office of Community Living. I'm here to introduce document 4, MSB 25-05-14-A, revision to the Medical Assistance Act rule concerning adult and child respite, sections 8.7545 and 8.7546. I do have accompanying slides to support my remarks as I walk through the proposal. And if possible, I would like to share my screen and share those slides.
Kelly, can we make that so for Corinna?
Is working on it, Madam Chair.
I appreciate you, gentlemen. Thank you.
Thank you so much, Kelly. You should be able to see my slides now.
We can. Go ahead.
Wonderful. As mentioned, this rulemaking concerns both adult respite sections 8.7545 and child respite sections 8.7546. The purpose of these revisions falls under 3 main categories. First, to improve service access. Second, to clarify policy. And third, to ensure alignment with existing waiver requirements. These updates are designed to remove vagueness, promote consistency, and better support members, families, and providers. I'll begin with the proposed rule updates to adult respite. First, under the Community Mental Health Supports Waiver, or CMHS waiver, the proposed rule clarifies that the approved service delivery locations for respite. Currently, rule-less respite is being available in nursing facilities, alternative care facilities, and in the home. However, there is no budget authority or federal approval to provide in-home respite under this waiver. This revision removes in-home respite from the CMHS rule and confirms that respite may only be provided in nursing facilities or alternative care facilities. This change aligns rule with the state's federal waiver agreement. Second, for the Supported Living Services or SLS waiver, the department proposes implementing a 30-day cap on respite days per support plan year. While this cap already exists within waiver requirements, it has not been previously reflected in rule. This change will ensure consistency with federal definitions of short-term respite and bring SLS in line with other home and community-based services waivers. This change only applies to respite day, which is the per diem that encompasses respite that's provided for more than 10 hours in a 24-hour period. This does not impact unit respite, which is set at less than 10 hours in a 24-hour period. It is estimated that this change will affect approximately 0.01% of SLS members. And for those members who do require additional respite beyond the 30-day limit, an existing exceptions process will remain available to address exceptional circumstances. I'll now move on to child respite, which applies to the Children's Extensive Support CES waiver, Children with Complex Health Needs CWCHN waiver, and Children's Habilitation Residential Program or CHIRP waiver. Across all three waivers, the department is proposing to clarify who may provide respite services. The updated rule will explicitly state that respite may not be provided by a legal guardian, primary caregiver, or legally responsible person. This limitation already exists in waiver language, but has not been previously reflected in rule. Adding it here ensures consistency and clarity for providers, families, and case managers. Next, the department proposes to clarify the process for over-the-cap respite exceptions, which is a process to exceed respite unit limits on an individual member basis. Currently, rule language identifies that exceptions may be approved for a member's age, disability, or unique family circumstance. This revision specifies that exceptions may instead be approved when there's a documented increase in medical or behavioral needs. This change creates objective criteria and ensures consistency. Additionally, the rule clarifies who may qualify for an over-the-cap respite exception. At present, caregivers who provide certain state plan services, such as home health, are excluded. The new language expands that exclusion to include caregivers who provide homemaker, personal care, or health maintenance activities, ensuring consistency with waiver provisions. For the Children with Complex Health Needs waiver, the department is proposing to establish an over-the-cap process for the first time. This will ensure that all child waiver members across CES, CWCHN, and CHIRP have access to the same respite exceptions based on the same criteria. There are two additional revisions specific to the Children's Habilitation Residential Program waiver. First, the rule removes language referencing specific limits for respite in foster care and kinship homes that are derived from the Colorado Department of Human Services, or CDHS's, foster family home care rules. Instead, the updated rule reflects those rules directly. This will allow CDHS to make updates to its rules and home standards without requiring separate revisions to the department's rule. Second, the department proposes to add a group respite service delivery model under CHIRP. Currently, CHIRP respite is provided only on an individual basis. The new group option will allow families with more than one child on a waiver to use a single provider for group respite, rather than having to have two separate providers or however many separate providers for each child. The change reduces administrative burden for families, providers, while still maintaining that service quality. This portion was included in the fiscal year 25-26 long bill. It's considered budget neutral, and it's expected to benefit approximately 2% of CHIRP members. The department first identified barriers to CHIRP group respite through stakeholder feedback from 2023. Formal stakeholder engagement sessions were held in August and October of this year. Stakeholders expressed broad support for the addition of group respite service delivery options to respite rules. The department did receive feedback suggesting revisions to the SLS 30-day cap language, which were incorporated into the current version of the rule you see before you today. We certainly appreciate the constructive engagement from our stakeholders who help make sure that these rule changes are practical, equitable, and well aligned with waiver intention. In conclusion, the department believes that these proposed revisions will clarify policy across adult and child waivers, enhance service access through the addition of group respite under CHIRP, and align rule language with federal waiver requirements and existing department practices. Again, the changes are cost neutral, they promote consistency, and will improve understanding and administration of respite services. Thank you for your time, consideration. Happy to answer any questions that you may have.
Thank you, Corinna. Do I have any questions from the board?
Madam Chair, this is James McLaughlin.
Go ahead, James.
Yeah, I was wondering if the department could provide, just to help me better understand how this respite differs from some of the other respite benefits, could you provide a case study outline of how this would be used or how this is used?
I can certainly do that. I will say for adult respite and child respite, the federal definitions of respite are pretty consistent. Excuse me, this is Karina Barrick. And those definitions are short-term and temporary care for when the primary caregiver is unavailable. How the department has broken down that is each waiver has different service delivery options. So service delivery options are the scope of where respite can be delivered, how it can be delivered, and who it can be delivered by. Hence, in the rule, you'll see some discussion with the adult waivers related to nursing facility, alternative care facilities. That does differ. Our children's waivers, depending on what child waiver, provides in-home respite. It provides respite overnight. It provides respite for shorter term. So respite does differ across the waivers. I will ask back, was there any specific authorization of respite on a waiver that I can provide an example for?
Yeah, I was just wondering, is there any exclusions if there's a behavioral health component? I mean, obviously, if there's not a facility, it'll take them, but are there any exclusions in the rule that prevents if there's a behavioral health component for them utilizing these waiver services?
That was James McLaughlin talking.
Sorry, Madam Chair, James McLaughlin.
Thank you so much for that question. This is Karina Barrick. There are no exclusions based on medical or behavioral needs and members receiving services. I will add and clarify under that respite service delivery options for two of our children's waivers, CHIRP and CES, there are two specialized options to provide respite for members who may have behavioral needs and medical needs. And so we do have a skilled and therapeutic respite service delivery option in order to meet members who have higher needs or different needs that need specialized care.
Is that for you, Mr. McLaughlin?
It does. Thank you, Madam Chair.
You bet. Do I have any other questions from the board?
This is Cassie Littler. I have a question about the family foster care homes for the CHIRP waiver. I see that the numbers for foster care, kinship care were removed from the document and refers to requirements for family foster care homes. And I just wondered where that document lives in order to ensure that foster care children are appropriately supervised when in respite.
Thank you so much for that question. This is Karina Barrick. Happy to answer that. The foster care home care rules live with the Colorado Department of Human Services, or CDHS. And the intention of this change was CDHS updates their rules as they will to ensure that the criteria for foster homes has been met. Rather than reflecting what's in their current rule and our current rule, we would refer directly to their set of documents in order for folks to follow guidance on those limits in the home for foster care respite.
Thank you for that clarification. I just wasn't sure if that family foster care homes provision was in the department of which department that was. So thank you for that. This is Cassie Littler speaking.
Thanks, Cassie. Do we have any other questions from the board?
This is James McLaughlin, Madam Chair.
Go ahead, James.
Not a question, just a statement. I just want to say that I have seen these services firsthand and how important they are for both the members and for the caregivers. I think this is a very valuable service, and I thank the department for putting the emphasis on this that they do. Thank you.
Thank you, Mr. McLaughlin. Do we have any other questions from the board? Hearing none. Mr. Sykes, do we have anyone signed up for public testimony on document 4?
This is Chris Sykes. Pardon me. We do not have anybody signed up for public testimony on this rule.
Terrific. I will accept a motion on document 4.
Madam Chair, this is James McLaughlin. I can take that.
Thank you, sir.
I move for the final adoption of document 04 MSB 25-05-14-A revision to the Medical Assistance Act rule concerning adult and child respite section 8.7545 and 8.7546, incorporating the statement and basis and purposes and specific statutory authority contained in the records.
Thank you, sir. May I have a second?
Barry Martineau, second.
Thank you, Dr. Martin. All in favor, please say aye.
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 All opposed? Abstentions? Wonderful. Document 4 passes. All righty, team. So we have one document, document 4, that we can talk about whether we'd like to put it on consent. Is there anybody who does not think document 4 should go on consent? Hearing no objections, Mr. Sykes, will you please move document 4 to consent agenda for next month?
This is Chris Sykes. Yes.
Wonderful. And with that, I am going to read the closing motion for the rules portion of the program. One moment while I pull that up. I move that all rules adopted at this meeting of the Medical Services Board of the Colorado Department of Healthcare Policy and Financing meet the criteria of the State Administrative Procedure Act, which are incorporated by reference. May I have a second?
Barry Martineau, second.
Thank you, Dr. Martin. All in favor? Aye.
Aye.
Opposed? Abstentions? Terrific, team. Rules portion is finished for today. And we go on to the open forum. Mr. Sykes, who do we have signed up for public testimony today?
This is Chris Sykes. We have Bryce Rafferty.
Wonderful. Are you there, Bryce? Oh, there you are. All righty, Bryce, just a reminder for the team, we're going to do a quick little notice about open forum. During open forum, the Medical Services Board welcomes the public to share testimony with us about matters not on the regular agenda. Please note that this board is a rule adopting body only and has no authority to address concerns or grievances against the department or its contractors. Testimony is limited to 2 minutes. Thank you in advance for sharing your time with us. Mr. Rafferty, sorry for false starting you, but now you get your 2 minutes.
Not at all. Good morning again, Madam Chair and members of the board. My name is Bryce Rafferty with CCDC. You've already heard from me today on specific rules, but I'd like to step back and talk about the pattern across all of today's emergency rules. Each rule has an objectively reasonable purpose. Implementing Amendment 79 and Senate Bill 183, tightening homemaker and protective oversight standards, aligning program integrity with Senate Bill 314, and fixing timely filing. But taken together, they point to something bigger. Emergency rulemaking is becoming a default way of doing business instead of the very narrow exception the APA intended. That matters because for people with disabilities on long-term care benefits like myself, rulemaking is part of due process. The standards and definitions inside tools like the Direct Care Services Calculator effectively decide whether someone can safely stay at home, whether a caregiver can keep a job, or whether a child with high supervision needs to get real support or is told it's just parental responsibility. When those standards are changed through emergency rules on compressed timelines and with limited stakeholder input, we're not tweaking technical language. We are moving the legal floor under thousands of people's lives without giving them a meaningful chance to be heard. I also recognize the pressures that you and the department are under, including the tail end of the PHE unwind, ongoing systems problems, increased JVC scrutiny, and the looming context and shock of HR 1. But in that context, emergency rules can feel like the only way to keep up. But the short-term relief comes with serious long-term risks, more erroneous reductions in appeals, deeper mistrust, and more arguments that the fee-for-service LTSS is unworkable and should be replaced by managed care models. There is another path, however. Reserve emergency rules for truly unforeseeable timing issues or immediate threats to health and public safety, not for deadlines we've seen coming for months or general budget speculations. When these tools and algorithms and standards effectively set benefit levels, bring their standards and methodology into full APA comment, notice, and comment rulemaking with clear explanations.
Thank you, Bryce. I appreciate you. This is Laura Carroll, President of the Medical Services Board. I first wanted to quickly respond to you and let you know that as a board, we often question when rules come up as emergency. It's something that we are paying attention to as a team also. And we agree, you know, a lot of this happened under COVID where everything became an emergency so quickly. And we as a board are paying attention to make sure that this is not becoming a casually wielded tool instead of the very precise measure that it is meant to be. And with emergency rules, just as a kind of reminder, those do not remain in impact. They are not permanent. They run, I believe it is, for 90 days. And within that time, the department is encouraged to then bring us a permanent rule if it is something that needs to stay in place. So I just want to make sure for folks who are listening that they understand that these rules that come in as emergency rules are by no means permanent. They are meant to be temporary. So I just wanted to pop that in there on the backside of Bryce mentioning the emergency rules, because it is something we're paying attention to, and I'm grateful that he is too. Do I have any other comments from the board?
Dr. Kennard here. I just want to make Bryce feel heard as well, that I'm one of the perhaps more vocal opponents of emergency rule, that they need justification. However, they do have to come back in 3 months, and I think we could even do a better job of highlighting when they do come back. This was an emergency rule you passed 3 months ago. These were the consequences. This is what's changed. This is how we screwed up, because sometimes you learn from a rule once it goes into place. Oh, that worked out okay, or no, it did not. So I think really highlighting this is this final adoption is, as we heard today, one that follows up on an emergency rule. That said, I think the bigger picture, that's beyond the scope of this board. I mean, that happens at elections and in the legislature. We can't affect that here. We don't have that much power, but we'll try.
If only, Dr. Kennard, if only. Do we have any other comments for Mr. Rafferty today?
Madam Chair, if I could just quickly make one clarifying comment.
I got you, Bryce.
Bryce Rafferty with CCDC. I very much appreciate the responses from the board. My concerns are more long-term, and I do understand and want to reiterate that these do come back, these emergency rules, for further consideration by the board. It's just that in the current context and circumstances that we find ourselves in, many things are not in our control, but there is a potential that a flurry of emergency rulemaking or rules will get lost in the shuffle, and the time and consideration that should be put into them in the first place via formal APA rulemaking may be offset by them getting lost in the shuffle. Taking that time and the iterative process of rulemaking is very important to get things right in the first place and can prevent foreseeable harm. So very thankful that you're taking this into consideration and look forward to further conversations.
Thank you, Bryce. Totally appreciate your voice at this table. I don't want you to ever think that we don't take your input seriously, because we do. All righty. Anybody else on the board wish to speak with Mr. Rafferty today? Hearing none. Thank you, sir. We appreciate your time at this meeting every single month. Do we have anybody else signed up for public testimony today, Mr. Sykes?
This is Chris Sykes. Pardon me. We do not have anybody else signed up for public testimony today.
Wonderful. Then we will go ahead and call that a day. It sounds to me like I have a department update today. I know that our friend Rachel, who would normally give that to us, is not feeling well. I understand that Mr. Sykes is going to act as your voice today, Rachel. Is that correct?
That is.
Thank you.
This is Chris Sykes. Yes, that is correct. We're encouraging, pardon me, Rachel to save her voice. for her family. All right, this is Chris Sykes, and I will give the department update. On October 31st, the governor, I apologize, I'm not losing my voice. The governor released his budget request to the Joint Budget Committee. The department's proposed annual budget for fiscal year 2026-2027 is $20.6 billion in total funds, including $5.99 billion in general funds. This represents an increase of $2.3 billion total funding, including a $413 million increase in general funds. That translates to about 96% of the total funds allocated to the department going to providers to care for our members. The funding allocated to the department in the governor's fiscal year 2026-2027 budget request represents 32% of the available general fund for the entire state budget. The HCPF budget also includes a reduction of $537 million total funding, including $217 million general fund. The $20.6 billion total fund is net of the $537 million total fund reductions. To balance the budget, HCPF will be proposing an additional $124 million general fund reduction with our January 2nd supplemental budget request package. I am going to say I am reading the department update. If you have questions, I am more than happy to write them down and get them back to our budget folks for a comprehensive answer. Okay, after the governor releases his budget request, the Joint Budget Committee enters into the start of their budget deliberations. First, Joint Budget Committee staff will present every agency's budget request to the Joint Budget Committee over the course of November and December. The Joint Budget Committee will have the opportunity to ask questions which are then passed back to the department to answer. Every department has a hearing in front of the Joint Budget Committee where those questions are answered as part of a presentation. Over the course of the legislative session, which begins on January 14th, 2026, the Joint Budget Committee will go through the process of finalizing and balancing the budget. This takes place in the form of the long bill, which needs to pass both the Colorado House and Senate and be signed by the governor. This will be the budget for the next state fiscal year beginning on July 1st, 2026. So Joint Budget Committee hearings are fast approaching, and these are the upcoming dates. On November 18th, the department and the Provider Rate Review Committee has a presentation from 9 to 10:30 a.m. And Kelly, are you sending out the links as I thank you? On December 5th, the Department of Human Services and HCPF behavioral health staff have a briefing from 9 to 11 a.m. On December 10th, I apologize, I have no idea what MSP staff briefing. What is MSP? I'm sorry. If anybody feels like chatting me, I would appreciate it, because we're not supposed to be.
Dr. Kennard here,
Yes.
Chris, just while we're waiting, I'm hoping this will all be just sent out to us with each of these committee meeting dates and
Yes.
whether or not they're open.
Absolutely.
So I don't have to write it down.
No, and then on December 15th, the Office of Community Living has a staff briefing from 1:30 to 3:30, and on January 5th, it is the overall department hearing from 9:30 to 5. That's an all-day.
Mr. Sykes, I just received note from Rachel that MSP is Medicare Savings Programs.
Thank you very much.
Medicare.
And yes, Kelly had sent that out, and I will be certain to email all of you just in case you are interested, plus all that information is on our website. And then, in other news, we have the Rural Health Transformation Program, and the department submitted our Rural Health Transformation Program application to CMS in early November. And the Rural Health Transformation Program was authorized by H.R. 1 to provide grants totaling $50 billion in federal funds from fiscal year 2026 through fiscal year 2030, so it'd be $10 billion per year to states. The program will be administered by CMS at the federal level and requires each state to submit an application and include a rural health transformation plan to the Department of Health and Human Services. Awards will be announced no later than December 31st, 2025, with funding to states in early 2026. These grants are federal funds only. States will not be required to provide matching funds to draw down these rural health transformation federal funds. There will be a stakeholder meeting before the end of the year, exact date and time to be announced as soon as we have details. And then Kelly should be chatting out. Here's where you can stay up to date with program news. And that is it for the department update. Are there any questions that I can take back and provide you with comprehensive answers?
I think for the Rural Health Transformation Program, just a clarification that the 10 billion is split in half, like part of it, split evenly amongst all the states, and the other half is what states can vie for based on their programmatic, like what their application is. And so how that lines out for what it looks like to us in Colorado would be helpful.
Certainly. This is Chris Sykes. I will take that back.
And sorry, this was Cassie Lilly.
Yeah.
Okay.
No
Are we
problem.
still in? We're not still in session.
An understanding of, yes, what that 10 billion per year to states looks like for Colorado specifically.
Yes.
Absolutely.
All righty, team. Do I have any other comments from the board, Tiny?
Yes, Madam Chair, thank you. I just wanted to throw out some gratitude real quick. First of all, I wanted to thank the staff from HIGPUF. I have noticed a really decent uptick in the number of times that they include stakeholding and stakeholding engagement in their rule requests. I want you to know those are looked at by us, and that input is really appreciated because it shows the hard work that you guys do on the back end. So thank you for that. Second of all, I want to thank the board, all the members of the board, the HIGPUF staff, and most especially Chris Sykes for facilitating the visit to our neck of the woods last month to Woodland Park. It was really nice to be able to share our community and all the amazing work that's going on there. That meant a lot to me that you guys would take the time to come and meet with our community partners. So thank you guys for that. And then last, I'd also like to say thank you so much for the amazing work that Nancy and her team did with the Rural Transformational Program. I know that was a huge undertaking with lots of interest. And I can say that I was very pleased with the final product that went out. Nothing is ever perfect, but from an EMS standpoint, from calling out mobile integrated health and community paramedicine and increasing access to care for patients in rural communities, I think you guys hit a home run with that application. So thank you very, very much for that. It means a ton to me, and it shows that the work that we're doing has been recognized and appreciated. That's it.
Thank you, James. Dr. Costello, do you have anything nice to say to anybody?
This is Dr. Costello. Yeah, actually, I just emailed this. Similar to what you said, I noticed at least during several of the presentations today, we're getting better information in the presentations, more financial information, I really like one that had real life examples.
Yes.
Yeah, that was super helpful at understanding really technical topics that many, if not most of us, are not experts in at all. In fact, don't know anything about when we start to read the rules. And so I appreciated that from both the HIPAA staff and from MSB staff, who I know have been working to improve the quality of presentation. So thank you. It makes for a slightly longer presentation, but I judge a much shorter discussion and a better product overall when we get more and better information up front that's really focused on a layperson, which again, many of us are. And again, I know it takes a little bit extra time, but it's great. Appreciate it. Chris, Rachel, everybody else who are supporting.
Yay, I love this stuff. This is the best part of the whole day. Does anybody else have anything nice to say? It feels like there's not that much of that these days, team. You know what I'm saying? All right. Well, let's leave on this really positive note. Good work this month, team. I will see you all in December. Thank you. Meeting is adjourned.
Thank you, Madam Chair.
Thanks, Madam Chair.
Everyone.
Be well, team.